All right. So thank you, Dr. Kwiatkowski and Recker, for this invitation. I'm honored and I feel very grateful for being here today amongst all of you to discuss the day after the USPSTF recommendation against PSA screening. So in May 2012, the USPSTF said we should stop doing PSA testing on the basis that Dr. Albertson just described, that the benefits do not outweigh the harms. So what response did the USPSTF get? Well, key opinion leaders in the field said that this better supports the grade C recommendation, which supports providing the service in an individual patient. Professor Schroeder, who is here in the audience, also said that decisions should be made on an individual basis, and you talked about risk stratification, which was not mentioned by the USPSTF. The AUA was not happy and said that the appropriate use of PSA testing can indeed reduce prostate cancer mortality. So the USPSTF is doing men a great disservice by discouraging its use. And that's why the AUA says shared decision-making for men 55 to 69 years, as we just heard. So will doctors follow the USPSTF recommendation? Let's look at what happened. After the 2008 recommendation, when they recommended against screening for men over the age of 75, we can see from using the Zero Medicare database that the incidence of early-stage disease did go down, especially in the older age group. However, this survey, before and after the recommendation, showed that these rates did not change. So what about the new recommendations? Let's look at 5 recent studies of what's happened. The first study was a survey of men's responses. Actually, 62% of men agreed with the recommendations, but only 13% intended to follow them. The majority still wanted to have a PSA test in the future. So consumers, that is patients, or actually men, are favorably disposed to PSA testing, and this recommendation was met with resistance. What did general practitioners say? This was a survey distributed at an annual retreat. 49% agreed, 36% disagreed, and 15% were indecisive. But then when they asked, how do you think this recommendation will change your approach to your PSA screening practice? Only 2% would no longer order routine PSA tests. 61% were somewhat or much less likely to do so, and only 38% would not change, and 30% would not change the practice at all. Then they asked oncologists and urologists. You see the green bars are the oncologists and the red bars are the urologists. In the age group 50 to 70 years, there is still an overwhelming support for PSA testing. In this study, they looked at data on all PSA tests in Ohio. And actually, you can see that the number of tests leveled off already after the 2009 conflicting publications from USPSA and PLCO. And again, you see a downward trend after the USPSTF, but it's very moderate. The greatest decline was seen among urologists and also in patients aged 50 to 59. And this is slightly worrisome because it's the age group that we wish to target, and yet rates are declining. The fifth study again looked at testing rates among general practitioners. You see a decrease, a small but significant decrease, and this was most evident in this study in the younger and the older age group, which is promising, and also among those who have a very low PSA. This suggests that GPs may be shifting towards a more selective screening approach, which is a good thing. All of these studies tells us that there is a reluctance against the USPSTF recommendation from key opinion leaders, from the AUA, from providers, and from patients. So why worry about this recommendation if we doctors aren't following it anyway? Another reason not to worry too much about this recommendation is because the review that was the basis for the recommendation contained a number of errors. And together with my colleagues, I wrote a paper in JCO outlining these errors. For example, the USPSTF says that one of the key questions is to look at all-cause mortality. The problem is that this is a basic statistical misunderstanding. PSA screening trials cannot reduce all-cause mortality because prostate cancer accounts for 3 to 6% of all deaths. That means we have a lot of statistical noise from death from other causes, so we have a very low power. As an illustration, imagine that you have a randomized trial that has an 80% power to detect a 0.5 absolute risk reduction or difference in prostate cancer mortality between the arms. So at 10 years, you have a 1% in the control group and 0.5 in the screening group. Overall mortality is very similar, 20 and 19.5%. The p-value for prostate cancer mortality is 0.01, a power of 80%, but for overall mortality, it's like a coin flip. The power is less than 10%. Next, they said that screening has no pooled effect on prostate cancer mortality. So when they compared all these screening trials, they assumed that they were comparable and that they were not very different, but in fact they're very heterogeneous. The Quebec and the Norrköping studies had methodological weaknesses. USPSA and Göteborg, high-quality trials, have indeed showed a difference in prostate cancer mortality. PLCO, also a high-quality trial, but was conducted in the US at a time when PSA screening was already widespread. Next, they said that the reduction in mortality was small or even non-existent. Well, this was based on an interim analysis from our trial at 9 years, and definitive conclusions cannot be drawn from ongoing trials. At 11 years, we consolidated our 9-year findings that prostate cancer screening can reduce prostate mortality by 21% relative risk reduction, but as Dr. Albertson pointed out, the absolute risk reduction is small, but it exists. With longer follow-up in the Göteborg trial that screens every 2 years, that screened younger men from 50 to 70, the risk was even greater. Not only randomized trial, but also observational studies shows that there is a 45% decline in prostate cancer mortality attributable to, but not limited to, PSA screening and improvements in treatment. And if you want to hear more about the evidence that PSA screening or early detection can reduce prostate cancer mortality, Saturday, 8 a.m., you should not sleep in. USPSTF said that 48 men were treated to prevent 1 death, but this is false. This was the number of men diagnosed, not treated, because in Göteborg, 25% of men were still on surveillance at last follow-up. And also, this statistic is very time-dependent, so with longer follow-up, this number decreases. And even though the absolute risk reduction might not increase, it might be stable, the excess incidence will reduce because the control group is catching up, so this number will become smaller. So let's try to understand the USPSTF. Let's try to be humble. What's wrong with the way we practice screening in the US? Let me give you 5 examples. Men are being screened without consent. 1 in 4 GPs order the PSA test without discussing it with the patient. So remember Dr. Recker, he said, think about Hippocrates, first do no harm. So unless you want to have this man showing up in your nightmares or your dreams, don't do this. Men are screened who are unlikely to benefit. As you can see from this graph, we screened 40% of men over the age of 70. We also screen men who have lung cancers, pancreatic cancers. Why would you screen those? Next, what is very important for addressing the overdiagnosis concern, men are being biopsied without compelling reasons. We're biopsying to the right and to the left. PSA has a very low specificity, and as Dr. Albertson pointed out, 3 out of 4 will not have cancer on biopsy, who have a modestly elevated PSA. And from the PCPT trial, we know that few men who have a low PSA have aggressive disease. PSA also has a tendency to fluctuate from one measurement to another, and yet we are biopsying on all these grounds. This is particularly concerning with the increasing hospital admissions and infectious complication rates, which is now up at 4%. Now, we're treating the majority of men with low-risk tumors, small volume Gleason 6, non-palpable tumors with low PSAs. This is beautifully evidenced by the Albertson tables, which become more and more beautiful over the years as he adds another layer to it with comorbidities. You can barely see the dark blue areas, which is prostate cancer mortality for men with non-palpable, moderately differentiated disease, because of the competing mortality of death from other causes. Yet, in the US, only 10% of men with low-risk tumors are being put on active surveillance or watchful waiting. Then, if we treatment is largely administered by low-volume providers. Can anyone tell me the typical annual radical prostatectomy caseload of a US surgeon in 2005? 50? 5? 1? 8? No one is more positive. 100? 10? This is particularly concerning because we know that there is a certain learning curve. This is for open radical prostatectomy, 250 cases. For conventional laparoscopy, the curve is even steeper, and for the robotic surgery, you need at least 40 cases. And we know that whose hands perform the surgery has a significant impact on outcomes. In this graph, each circle represents one surgeon, and the size of the circle is proportionate to the caseload. So you can see that the larger circles, the high-volume surgeons, have better functional outcomes and oncologic outcomes. And this is case mix adjusted data. So it's not the robot who's doing it, it's who's doing the robot. So if we're doing all of this wrong, should we just stop PSA screening? Or do we need some sort of screening? Well, let's ask ourselves, do we really want to go back to seeing these clinical scenarios? Patients come in with kidney failures, they come in with bone pain, or even spinal cord compression. Our trial, USPSA, has shown that screening can reduce the incidence of metastatic disease, both at diagnosis and during follow-up. Because without PSA screening, what would happen? Well, if you look at the pre-PSA era and then post what's going on now, the total number of men with metastatic disease would be 3 times greater without screening. So to sum up, we have evidence of a reluctance to the 2012 USPSTF recommendation. We have evidence that what we're doing now is not ideal. We have evidence that screening has the potential to reduce metastatic disease and prostate cancer mortality. So instead of stopping PSA screening, we have the potential to stop this. But there is a time for a more balanced perspective, and we should not need to just stop doing screening. We need to refine the way we do it so we can shift the ratio of harms to benefits. The way forward is to use a risk-stratified approach. We want to find 100% of those 3 to 6% lethal diseases. We can take advantage of knowing that the level of PSA has a strong relationship with future outcomes. However, as Dr. Albertson pointed out, this needs further study. And I think Dr. Lilja will present some of this. We can take use of risk calculators, and Professor Robol will present this in Stockholm at the EAU, that she has now created an app that you can download to your iPhone. Maybe in the future we can use this fella to better screen. So it ain't what you do, it's the way you do it. I think it's an old rock song or something. So if you today want to improve the ratio of harms to benefits by the way you're practicing screening. Follow these 5 golden rules. Get consent. Don't screen men who won't benefit, elderly men with comorbidities. Don't biopsy unless you have a compelling reason. Don't immediately treat men with low-risk disease. Consider active surveillance. And if you have to treat, try to do so at a high-volume center. Thank you.
Okay, thank you, Peter and Sigrid. This was